Hello, good morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from Japan, Dr. Shunsuke Shibao. Dr. Shibao is a lecturer in the Department of Neurosurgery at the Tokyo Medical University, Japan. He was the previous head of Neurosurgery 1 at the Department of Neurosurgery, Ashikaga Red Cross Hospital. He was a previous skull-based fellow at the Padjadjaran University, Indonesia. His clinical interest is focused upon minimally invasive as well as open skull-based surgery. We are extremely honored to have him today at our webinars, and today he'll be talking about modification of anterior petrosectomy. The speaker for the second session of today is our honored guest from China, Dr. Liang Zhu. Dr. Zhu is a consultant neurosurgeon at the Zhejiang University School of Medicine in China. He is an expert in the field of intervention neuroradiology and has published several articles in various peer-reviewed journals. He works with Professor Yu Jun at the Zhejiang Medical University, and we are extremely honored to have him today at our webinars. And today he'll be talking about an eye for an eye, the therapeutic strategies for cavernous sinus AV fistulas. The chair for the first session of today's webinar is our honorable guest from Lausanne, Switzerland, Professor Roy Thomas Daniel. Prof. Roy is the Vice Chairman of Neurosurgery in Chu, Lausanne. He is an active member of the skull-based session of the ACNS, and he has published several articles and detailed the treatment guidelines for treatment of several brain tumors. He has developed several innovative surgical techniques for treatment of skull-based tumors, principally by a combination of surgical approach, namely transcranial, along with minimally invasive transnasal endoscopic surgery and radiosurgery. He has published several articles that details the treatment guidelines for this kind of tumors, and we are extremely grateful to him for accepting an invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is an honorable guest from Japan, Prof. Takahiro Ota. Prof. Ota is hybrid vascular neurosurgeon and director of neurosurgery at the Tokyo Metropolitan Tama Medical Center. He is a stroke specialist certified by the Japan Stroke Society and is a board certified trainer of the Japanese Society of Neuroendovascular Therapy and the Japanese Society on Surgery for Stroke. He is a vastly experienced surgeon who has performed over 1,200 endovascular procedures for aneurysms and AVMs and more than 300 brain tumor surgeries. His clinical interests are focused upon microneurosurgery, endovascular neurosurgery for brain and spinal cord lesions, and has published extensively in various peer-reviewed journals. We are extremely grateful and honored to have him today at our webinars to chair the second session. On behalf of the Education Committee of the ACNS and the President Prof. Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Prof. Shubin for broadcasting this webinar on the WeChat channel. Dr. Libun Singh from Malaysia is my co-host for today. And with that introduction, I would like to hand over this online podium to our first chair, Professor Roy Thomas Daniel.
Thank you, Raja. It's a great honor for this invitation to chair this session. I really have to commend your work, Professor Raja Krishnamurthy. The work you do for chairing these sessions has a huge impact, and many people in Europe I know are actively watching these webinars, and you always get the best people for each topic. The topic you've selected today, it's very close to my heart, and I love this anterior transpetrocellular approach because it is something that is a key to the skull base in that region, the petroclival region, and has very many applications as can be seen in the large number of publications coming out. And I'm particularly happy to see that you called Professor Shunsuke Shibao, who has published a lot in this region. I was happy to see the modifications that he has described so far, and even the work he's done on developing instruments in neurosurgery. And particularly also the historical article he wrote on Professor Kawase. It is so nice to read that some of our heroes in neurosurgery being commended for their contributions to our specialty. So without any more explanation, I look forward to hearing this lecture from Professor Shibao from Tokyo, Japan.
I'm very truly honored to be invited for this ACNS webinar on this occasion. So I'd like to talk about modification of anterior transpersonal approach. The anterior transpersonal approach is essentially avian subdural subtemporal approach, subtemporal anterior petrosal transtentorial approach. And this approach is reported by Professor Kawase in 1985. He is my mentor And I co-authored his biography with Dr. Ganaha. So in this article, we focused on development of Carl's approach and his contribution to education and his patient-centered philosophy. So please read this paper. Introduction. The anterior transpetrosal approach is a well-established surgical method for accessing the petroclival region. Various modifications of ATPA have been developed to address specific surgical challenges. We reported some ATPA modification based on the database of the Keio University. So the ATPA modification includes a modification for venous preservation, a combination with other techniques, and simplification of ATPA. The first modification is for venous preservation. The modification for venous preservation includes preservation of superficial middle cerebral vein, SMCV, and veins under the temporal lobe. First, I will explain the preservation of the superficial middle cerebral vein. We propose the classification of SMCV for venous preservation during the anterior transpetrosal approach. The type 1 is cavernous absent type. Type 2 is sinobasal type. Type 2A further divided into type 2A medial type and type 2B lateral type. Type 3 is sphenopetrosal type. Further subdivided into the type 3A vein, type 3B vein and sinus, type 3C and sinus. So in type 2B, type 2B, 3B, and 3C, there's a risk of venous drainage impairment with a standard anterior transpetrosal approach. So we propose the modification of the anterior ATPA for SMCB preservation. For type 2B, lateral sinobasal vein, the combined AP and subdural anterior petrosectomy was applied. Type 3B, sphenopetrosal vein and sinus, the dural incision should be made anterior to transition between vein and sinus here. For type 3C, sphenopetrosal sinus, subdural anterior transpetrosal approach should be applied. First, I will present the representative case of subdural ATPA. The 68 years old female with right petroclival meningioma extending from the right petroclival junction to the Meckel's cave. The preoperative CT venography shows the SMCV is of sphenopetrosal type, and this vein drainage into the foramen ovale and continue with the vein around the petrosal area. So there is a risk of venous injury during extradural dissection and dural incision in standard ATPA. So we plan to perform subdural ATPA in this case. Operative video. The temporal craniotomy was performed. The temporal dura was open and entered subdural space. So I identify the temporal vein, run into the interdural space like this, and continue to the arcuate eminence area. So GSPN was identified by the patient monitoring, and the dural incision was started just medial to the GSPN. The petrous bone was exposed to the petrous edge, and the GSPN was dissected medial to lateral. the interdural dissection is important. Here is a trigeminal impression here, and calcium triangle was exposed here. The calcium triangle was drilled. The posterior fossa was exposed. The bone under the Meckel cave was removed. So the posterior fossa was incised. The SPS around the posterior attachment of the tumor was cut. Here is the tentorial edge. The trochlear nerve was identified, and the CSF leak CSF was removed. Dural incision was made, and the tumor was dissected from the trigeminal nerve. Open the Meckel cave, and the tumor inside the Meckel cave was dissected and removed. The dura around the anterior tumor attachment is incised. Here is a Parkinson triangle. The feeding artery is disrupted. The trigeminal nerve was dissected. So the trochlear nerve, here's trochlear nerve is dissected and preserved. The final adhesion of the trigeminal nerve was dissected, and finally tumor was taken. This is petrosal vein was preserved. The residual tumor around the trochlear nerve was removed. The post-operative MRI shows the total removal, and the transient trochlear nerve palsy was found and improved 9 months post-operatively. The post-operative CT venography shows venous preservation. The next is next I will show the representative case of the combined AP and subdural anterior petrosectomy. The 45 years old male presented with trigeminal neuralgia. MRI shows a light petroclival meningioma and vein draining into the foramen ovale here. So to preserve this vein, we apply the combined AP and subdural anterior petrosectomy. Here is the subdural space, and here is the epidural space. The operative video. Open the temporal lobe dura and enter the subdural space. And we confirm the vein drain into the foramen ovale around here. So the dura around here is not dissected, is important. The dura posterior middle fossa dura is dissected epidurally, and here is DSPN. The medial to DSPN was dissected. So calcium triangle was exposed. Here is epidural, and here is subdural. The calcium triangle was drilled to make the space to cut the superior petrosal sinus. The superior petrosal sinus was cut, and tentorium was incised to the tentorial edge. Here is the anterior part of the tentorium is cut. Here is a Parkinson triangle, and the feeding artery was disrupted. The tumor was dissected surrounding structures such as trigeminal nerve and trochlear nerve, and arachnoid membrane is preserved to the normal structure. Finally, the tumor was taken. The residual tumor attachment is removed. The post-operative MRI shows a total removal, and we confirm the preservation of the vein draining into the foramen valley here. The next, I will explain the preservation of vein under the temporal lobe. The immediate cranial fossa approach, including the ATPA, bridging vein, transitioning from subdural space to interdural space, is very important. We classify the subtemporal bridging vein during ATPA into tentorial group here, middle fossa group here. Middle fossa group further subdivided into the cavernous sinus, middle fossa dural sinus, and middle fossa dural adhesion subgroups. The tentorial group includes temporal basal vein and basal vein of Rosenthal. The cavernous sinus group of middle fossa group includes temporal basal vein. The middle fossa dural sinus subgroup of middle fossa group includes temporal basal vein and petrosal vein. The middle fossa dural adhesion subgroup includes sphenopetrosal vein. So we propose a procedure for preservation of subtemporal bridging vein. For tentorial group, the tentorium was incised, should be incised, avoiding bridging point here. For middle fossa dural sinus, the middle fossa dural incision should be performed just anterior to bridging point here. For middle fossa dural adhesion, the careful dissection of vein adhered to middle fossa dura is important. So I will show the representative case of middle fossa dural adhesion case. A 75 years old female, left trigeminal neuralgia. MRI showed the left small petotentorial meningioma here. Preoperative CT scan shows a developed air cell in petrous apex and craniotomy, temporal craniotomy limb. There are high risk of CSF leakage. For strategy, because of old age and small lesion, we plan to perform endoscopic assisted subdural ATPA with small craniotomy as minimally invasive approach. Preoperative CB venography shows that SMCB is cavernous type, and subdural subtemporal vein here. It is important which this vein is middle fossa dural sinus or adhesion. The L-shaped skin incision was designed and small craniotomy was performed. The operative video, the dura was opened and entered subdural space. The subtemporal, we identify the subtemporal vein, middle fossa adhesion type. So the carefully dissected the vein and make the space to incise the dura. The dura was incised intradurally and exposed the calcium triangle. In this case, the calcium triangle was drilled under the endoscope, and the posterior dura was incised. The SPS and tentorium was cut, and finally tumor was taken. So, Yeah. Under endoscope, we check the tumor removal. Fat tissue was packed in the petrous apex air cells. The post-operative MRI showed the total removal, tumor removal, and trigeminal neuralgia resolved. No other complication, including venous injury and CSF leakage, not found. Here is a preoperative prediction of venous bridging point using curved planar reconstruction. Target veins ROI was selected, and long and short diameter of its cross-section were measured to calculate the flattening ratio. Here's the flattening ratio. Interdural sinus was significantly more flattened compared to subdural veins here and here. So this data is useful for distinguish between subdural vein and interdural sinus preoperatively. The next modification is combination with other techniques. Based on our experience, we consider the limitation of ATPA to be anterior to ICA anterior loop, 1 centimeter posterior to internal auditory canal, and inferior to jugular tubercle. For region beyond the limitation of ATPA, we should combination with other techniques. The combination with other techniques includes Trautmann triangle resection, namely ATPA combined with partial posterior petrosectomy, and endoscopic and nasal approach. First, I will explain the Trautmann triangle resection. The ATPA combined with partial posterior petrosectomy was applied for the petrochival meningioma extending posteriorly beyond the posterior limit of the ATPA. In petrochival meningioma extending posteriorly, it is necessary to make space for ligating posterior part of SPS and secure the posterior surgical field. Yeah. To achieve this, we use the Trautmann triangle bordered by middle cranial fossa superiorly, posterior fossa or anterior to sigma sinus posteriorly, semicircular canals anteriorly, and jugular valve inferiorly. So the key surgical techniques includes the adequate dissection of petrous edge for ligating posterior part of SPS, and sufficient exposure of petrous bone posterior surface to secure the posterior operative field. So for the preservation, functional preservation, we aim to minimize the bone resection, avoiding exposure of critical structure such as attic, labyrinthine, and facial nerve. This method is called partial posterior petrosectomy. Here's the representative case. 69-year-old female presented with light dysphagia. MRI showed the left petrochival meningioma extending posteriorly beyond the posterior limits of ATPA. Operative video. The temporal craniotomy was performed. The temporal dura was dissected extradurally. First, we identified the MMA, and the MMA was coagulated and cut in the foramen spinosum. Coagulate cut. Next, the partial posterior petrosectomy was performed. Here is the Trautmann triangle. Here is sigmoid sinus, partially exposed. Next, I dissect the GSPN and expose the carotid triangle. And there is a carotid triangle. And the petrous edge of the anterior portion along the SPS. Next, I open the antrum and enlarge the tradon triangle. And there is a petrous edge along the posterior part of the SPS. Here is the tradon triangle. Here is the carotid triangle. The temporal dura was open. And inside along the SPS, anterior and posteriorly, the posterior dura was incised. Here is the petrosal vein. So the posterior part of the SPS was ligated, just anterior to the entering point of the petrosal vein. The temporal edge was cut, and posterior part of the tumor was dissected from trigeminal nerve. And here's trochlear nerve. And tumor was divided at the posterior to the entering point of trochlear nerve to the tentorium. The Meckel cave was open. The tumor inside the Meckel cave was taken. Adhesion to the trigeminal nerve was very strong. And we take the tumor as much as possible. The post-operative MRI shows the tumor removal except for cavernous sinus portion. The transient aphasia due to venous drainage impairment was found, but improved 3 months post-operatively. The next combination is the endoscopic endonasal approach. Here's the representative case. 35 years old male presented with dizziness, diplopia, and headache. MRI showed the large tumor extending into middle cranial fossa, petrous apex, jugular foramen, sphenoid sinus, and internal auditory canal. Yeah. The neurological findings include left abducens nerve palsy, hearing disturbance, and higher cognitive dysfunction, such as episodic memory impairment and transcortical sensory aphasia. The first operation was done via left anterior transpedorsal approach for the purpose of tumor reduction, abducens nerve decompression, and diagnosis. We removed middle cranial fossa tumor here, and tumor around the petrous apex and jugular tuberculum here. The post-operative MRI shows the tumor removal in middle cranial fossa, petrous apex, and around jugular foramen. But the residual tumor remains in sphenoid sinus and around the ICA. So post-operatively, the left abducens nerve palsy and higher cognitive dysfunction improved, dizziness and headache resolved, hearing disturbance improved, transient facial palsy was found and resolved within 2 months post-operatively. No CSF leakage was found. The pathological diagnosis was chondrosarcoma. The second operation was performed 4 months after the initial surgery. The endoscopic endonasal tumor resection was performed via transmaxillary approach for the purpose of tumor resection around the optic nerve. We resected the tumor within lateral recess of sphenoid sinus here and here. The postoperative MRI showed the tumor resection in the sphenoid sinus, and the residual tumor remains posterior to ICA here. Postoperatively, the radiation therapy was planned, and he was referred to another hospital for gamma knife. The last modification is simplification of ATPA. The simplified ATPA with a SPS and temporary incision was applied for the lesion centered in Meckel's cave. I will show the procedure of simplified ATPA. After anterior petrosectomy, posterior procedure and inferior wall of the Meckel's cave were incised to expose the tumor here without incising the SPS and tentorium. This is important. This is comparison of standard ATPA and simplified ATPA. The simplified ATPA avoid SPS ligation, tentorial incision, and middle procedural incision. The avoiding SPS ligation reduces the risk of venous drainage impairment. Avoiding tentorial incision reduces risk of trochlear nerve injury, and avoiding middle procedural incision reduces risk of temporal injury. Here's the representative case of simplified ATPA. A 70 years old female with right Meckel's cave metastatic tumor here. We applied the simplified ATPA to approach the Meckel's cave lesion here. And we also apply simplified ATPA is also applied the tumor other than Meckel's cave as a minimally invasive approach. Here's a representative case. 55 years old female with right Petrous apex meningioma. The surgery and radiation therapy for pituitary germ cell tumor 30 years ago. So radiation-induced meningioma was suspected. Preoperative venous evaluation revealed vein bridging from the brainstem and superior surface of cerebrum to the tentorial edge here and here. And the tentorial sinus continued to the cavernous sinus here and here. So as for preoperative strategy, we want to avoid SPS and tentorial ligation to preserve petrosal vein and tentorial sinus. And tumors located around the inferior part of the Petrous apex. So we plan to perform simplified ATPA without SPS and tentorial ligation combined with endoscope. The operative video. The AR is used to confirm the location of craniotomy. The temporal craniotomy performed, and the dura was dissected extradurally. The MMA was coagulated and cut. The arcuate eminence was exposed, dissected. The GSPN was identified and dissected. They exposed the calcium triangle. The calcium triangle was drilled. In this case, the calcium triangle was widely dissected to manipulate the inferior part of the Petrous apex. Here's the inferior part, Petrous apex. The opposite posterior procedure and expose the tumor. The tumor is decompressed by QSAR and dissect the brainstem. Here is the abducens nerve. The tumor divided along the abducens nerve. The lateral to the part of the to the abducens nerve is removed. The endoscope was introduced in this stage. The clear review is obtained around the tumor. This is the monitor arrangement. The exoscope monitor is used to check the structure in front of the endoscope. The tumor was dissected from the brainstem. Under endoscopy, the dissection plane is very clearly visible. The attachment, clival attachment is not visible under the microscope, while under the endoscope, the dual clival attachment is visible clearly. So the tumor detachment is completed under the endoscope, and tumor was taken. The non-residual tumor was confirmed under the endoscope. The post-operative MRI shows the total removal and no complication was found. The 15 ATPA cases were performed from June 2019 to July 2024. Among them, modification of ATPA was performed in 8 cases, 53.3%. Modification of ATPA includes venous preservation 3 cases, combination with other techniques in 2 cases, and simplification of ATPA in 2 cases. Clinical outcomes, gross total removal was achieved 53.3%. Transient brain edema was found 2 cases. Permanent cranial nerve deficit includes trochlear nerve disturbance 3, patient nerve palsy 1. No CSF leakage was found. In conclusion, ATPA can be modified in various ways to enhance safety and effectiveness, depend on specific surgical goals. Tailoring the approach to the surgical objectives is crucial for optimized outcomes. Thank you for attention.
Thank you, Dr. Shibao,
Thank you.
for a brilliant talk. I really appreciate how you have analyzed so clearly the anterior petrosectomy, including all the modifications. And I looked at your statistics, about half your cases you have modified the approach or you have simplified it. That shows a dedication to the specialty, very, very organized methodology to make sure that we can make the best outcomes for our patients by analyzing the images. I was particularly impressed with the way you used the CT angiographic sequences, and how you spend a lot of time. I have a feeling you have spent more time on the preoperative imaging than you have spent in the operating room, which is the ideal way of doing surgery. Actually, the more you think about a surgery, the easier and faster the surgery becomes, and much, much more safer. Congratulations to your efforts in simplifying this procedure and modifying this procedure and studying it scientifically. I loved your videos, and I look forward to seeing more of your work. So I leave the floor open to more suggestions, questions, commentaries.
Thank you very much. There is a question in the chat box. Any issues you have inquired for the vein of labia injury or thrombosis?
Thank you. Yeah, in the anterior transpersonal approach, the lab injury is not problem in most cases. So I have not encountered this kind of injury.
Well, I have not seen it myself, but I know from literature that the vein of Labbé very rarely can drain directly into the superior petrosal sinus. So that is something that needs to be looked at in the preoperative angio-CT. Fortunately, it is very rare. I've never seen it myself.
Thank you very much. Any questions from the floor, Dr. Liu?
Yeah, thank you. Thank you for a very excellent talk. I have many three.
You are muted. Liu, can you please unmute?
Sorry. Sorry. Thank you for a nice lecture. You identify those vein, vessel vein from the pre-op venogram, and intraoperatively, how do you identify those vein? Either you use ICG venogram, or you use ultrasound, or by IGS. So how exactly the position that you want to go lateral or medial to the vein? That's my first question. My second question, Professor, you did show there are cases also still have some temporal edema, because we used to associate temporal edema due to a venous injury. So in those cases, do you think that what other possible cause, because you try to preserve the vein, but there are some cases with temporal edema, is it due to the more or less retraction to the temporal lobe by doing a subdural technique? And I also observed that you cut dura near to the edge, and you mainly use the dura to protect the temporal lobe, which are excellent technique rather than big incision of the dura. My last question, Professor, you show also, I think most people are doing it now, having exoscope to observe externally from the endoscope view. Do you assign any surgeon to look at the monitor of the exoscope to make sure there's no interruption during insertion of the endoscope or exit of the endoscope? And do you think that there's role to have some cylinder type, like what we use to use for intraaxial lesion when you use the endoscope? Would that be helpful, no? When you insert the endoscope to cause any injury at the external area of the temporal fossa? Thank you, Professor.
Thank you. For the first question, during surgery operation, I will check the vein, the direct observation. So the IgG is used for the confirmation of the venous preservation. The Doppler is also used to check the location of sinus, such as superior petrosal sinus or sigmoid and transverse sinus. And for the second question, the
temporal edema, your cases.
temporal edema is very important issue. The temporal edema will maybe occurred by the temporal retraction and the combination of temporal retraction and the venous drainage impairment. So I use the spinal drainage to reduce the temporal intracranial pressure, reduce the intracranial pressure. So the third question is
the exoscope.
Exoscope. I have not. I don't have the exoscope, and
So you use microscope or exoscope?
Yeah. I check the surrounding structure of the endoscope. So maybe the middle fossa area is there's few important structure compared to the suboccipital corridor, such as facial nerve or auditory nerve. So the endoscope of the during the anti-petrosal approach is very safe, I think. And but the check the structure in front of the endoscope is necessary.
Do you assign one of the surgeon to observe the external part of the view? I mean, you have two screen. One person to look at one screen, another person look at another screen for the safety purposes.
Yes, I use two screen.
Yes.
Yeah, endoscope and exoscope.
Yes. Okay. Thank you, Professor.
Yeah, in partial answer to Professor Liu, I think temporal lobe edema can be a lot decreased if the intertentorial approach can be used. That way, you can keep one layer of dura on the temporal lobe, which is all the way up to the tentorial hiatus. So that has eliminated this temporal lobe edema, at least in my small experience. But then, when you decide to split the tentorium, you should look at all the variations of venous anatomy, which Shunsuke showed very well. So I think the data that he brings to the table is important to see if an intertentorial approach can be safely used. But that does take care of the temporal lobe problems.
Thank you, Professor Roy.
Thank you for this wonderful comments, Prof. Roy. One question I would like to put across to Dr. Shibao is that if you see in the Osaka by Prof. Osaka University Neurosurgery, that Prof. Goto has almost totally transitioned into the subtemporal keyhole approach for this Kawase. So, have you considered yourself following the same lines ahead in the future?
Yeah, keyhole subtemporal approach, endoscopic approach is very useful, I think. But it needs very high technical skill and high skill team. So, but I select the case for use such a approach. I selected the patient.
Thank you very much.
I think the selection of the approach is very important, and your comment, Raja, is very appropriate because we have just now sent for publication a minimally invasive anterior petrosectomy intertentorial approach for treatment of trigeminal neuralgia. So that's an excellent indication because a very small approach can be done towards the trigeminal nerve, which I think is much safer than the existing standard, which is the retrosigmoid craniotomy. So I don't know how much acceptability it will get in international literature, but hopefully when the article comes out, I'll know and we'll know.
Yes, thank you. Dr. Ben, any comments from you?
Yes. And first of all, congratulations and to your talk and Professor Shibo. And also, I'm very glad and Professor Royal Daniel is here. He's one of the experts that I still remember your lectures in the interdural dissection during the Petrosal approach, and I think it totally matched the topic. So I learned so much from your lectures. I just want to know one thing is that do you think is ever necessary to take down the zygomatic arch? In what situation that you would take down the zygomatic arch?
In most cases, zygomatic arch resection is not necessary.
Yes.
Basically, the look down surgical corridor in the anterior petrosal approach. So that
yes, because I see you have a combination with other types of approach. But sometimes for the pathology, you may need to consider to combine the petrosal approach with the Dolan approach. So just want to see whether you have encountered these things and how you would modify your petrosectomy when you combine with the other approach.
The complex approach, such as zygomatic or endonasal approach, is needed. The second stage surgery will be applied for the such complex approach. It is depends on tumor extension is important. The tumor extension will decide the needed approach. And so it is necessary to see the limitation of anterior thoracic approach and the region extension should be considered for to select another approach. I think.
Well, I would agree with Professor Shibao. So it's basically the question is, do you want one big approaches or two relatively small approaches? So it is essentially based on the extension. So very often with anterior petrosectomy, a fair amount of the petroclival region can be addressed. Like Professor Shibao showed, there is certain limits that are well defined in literature. But when it goes beyond the limits, you have to add on. So one beautiful addition which he showed was a partial posterior petrosectomy. What that does is that it allows you to even retract and posteriorly translocate the transverse sigmoid junction, so that it will give you a little bit of upward view. So the challenge very often in petrosectomy approaches is to see something near the oculomotor nerve, oculomotor triangle, where the oculomotor enters the cavernous sinus. So you need to look from below upwards to see that. Now, if anything goes beyond that, then of course we have to add on an a posterior transcavernous approach onto the anterior petrosectomy. So any of either the anterior or the posterior extensions can be done, but then that has to be balanced with two approaches. That means an endonasal alternative could be an alternative to doing a very big approach. So this is a philosophy that some people like to have one big approach, some people like to do it in two different approaches. So both are very viable techniques.
Yes, and I totally agree, because sometimes it's complicated. Because, for example, in posterior petrosectomy approach as described by you, when you combine it with the anterior petrosectomy, you can visualize those that especially scipic through the oculomotor triangle. But but you can, at the same time, you could also consider doing the anterior approach. For example, you can do the Dolan with the transcavernous approach. So you could also do that. So no, I'm just asking about how you would plan and how you would decision making. I think there's no fixed answer. It depends on the expertise and also the tumor extent. So I just appreciate your work, and also Professor Daniel's works. And thank you so much for your comment.
Thank you, Ben. I think we will wind the first session up now, as it's already time. We will take the concluding remarks from Prof. Troy Daniel.
Thank you, Raja. It has been a great opportunity and a very nice time we have to discuss this topic with Professor Shibao and other colleagues. Thank you again for inviting me, and I hand it back to Raja for the second session.
Well, thank you very much. We'll be glad if you could stay back, but nevertheless, if you're busy, I understand. So thank you very much, Prof. Roy Daniel and Prof. Shibao. We'll move on to the second session, and I'll hand the podium over to our Honorable Chair, Professor Takahiro Ota from Tokyo. Prof. Ota, all yours.
Yeah, thank you, Raja. I'd like to thank you, Professor Raja and Professor Kato, to invite me as the chair of the second speaker today. The second speaker is Professor Yu Zhen from China. He's lecture title is An Eye for an Eye, Therapeutic Strategy for Cavernous Sinus AVF. It's a very interesting topic, and cavernous sinus dural AVF needs to treat it via several approaches. So I'm excited to hear his lectures. So, Professor Eugene, are you online?
Professor Liang Zhu is talking on
Eugene.
behalf of Dr. Yujun.
Okay.
Thank you, Professor Raja, and thank you for everyone for having me here tonight. So I'm gonna share the topic of the an eye for an eye therapeutic strategy for the cavernous sinus arteriovenous fistula. So here, this is a campus I work in. I worked with Dr. Eugene. So actually, I'm giving this lecture on behalf of Dr. Eugene. Back to 1985, Professor Borrow has classified this fistula, the cavernous sinus fistula, into 4 categories. So the type A is a direct ICA cavernous sinus fistula, which, as we all know, is usually caused by traumatic injury or spontaneous ruptured aneurysm. But we are going to talk about this type of this type of cavernous sinus fistula today. So the type B and C and D, these types of fistula is supplied by the branches either of the ICA or of the ECA. So this is an indirect cavernous sinus fistula, and we are going to talk about the treatment of this indirect fistula tonight. So as we all know that the manifestation of the cavernous sinus fistula is mainly dependent on the drainage pattern of this disease. Usually, it's drained by the SOV, those superior ophthalmic veins. So the dilated the SOV will cause the symptoms of the eyes. And for the other drainage ways is usually it can drain by the inferior patch sinus. For this kind of disease, in this circumstance, it's very easy to embolize these fistula using the IPS approach. So for the IPS occluded cases, it's usually very difficult to call this kind of the disease. So back in history, we tried the trans artery embolizations. I'll give some time to review the artery, the supply of the cavernous sinus durals. The blood supply of the cavernous sinus, the dural of cavernous sinus usually by branches from the IC and the ECA. So the branches of the ICA usually are posterior ethmoidal arteries and the meningofascial trunk, the recurrent branches from the ophthalmic arteries, and the inferior lateral trunks and the medium clavus arteries. So these kind of branches are not suitable for catheterized, and the other blood supplies are from the branches of the ECA, which are middle meningeal arteries and submeningeal arteries and ascending pharyngeal arteries. And we usually use these branches for catheterization. So before 2016, we have accomplished trans artery embolization in 21 patients, and among them, 17 of the patients acquired total embolization. And the permanent complications are the cranial nerve palsy and also the ectopic embolization. So by ectopic embolization, I mean the embolization in the ICA system. So this is the case that this patient had ectopic embolization in the MCA. So it is very dangerous to using the trans artery embolization approach. So we started to try the transvenous embolization after that. So as we all know that if the IPS occluded, we can either go the we can either go the IPS recannulation or the trans SOV approach. So we started to do that in after 2016. This is a primary result from the 2016. We did it in 12 patients. So 10 patients acquired total occlusion, one patient did not acquire embolization because of technical failure, because we cannot advance the microcaster into the fistula point. And the one patient had partial occlusion, but none of these patients had severe complications. So compared to the transartery embolization group, the immediate occlusion rate seems to be fair, but it looks like it's much safer in the transvenous approach. So we started to do transvenous embolization from the after then. So this is data from the next year, the 2017. So we did 4 more cases in transartery embolization, and we did 60 more patients in transvenous approach. So when you enlarge the patient samples, you can see the significant the embolization rates in the transvenous embolization, which is 92.85% compared to the 68% in the transartery embolization. And the more important is in the transvenous embolization, it is exactly much safer. We didn't have very severe complications such as ectopic embolization in the ICA system. So we abandoned artery embolization from 2017, and we started to do the cases all by transvenous embolization. And we tried it different ways. Some of the doctors did it by RPS recannulation, but personally, I prefer the SOV approach. The idea of SOV approach is what we is, as we all know, that is the manifestation of the cavernous sinus fistula is usually on the eye. So usually these kind of patients, they had in undilated SOV. So I use this way to cure this disease. So so from the 2017 and 2023, I summarized this data of cavernous sinus dural arterial venous fistula. There were 104 patients overall, and we adopted transvenous approach in 79 patients, and among them 32 patients were managed by SOV approach. So this is overall data of these 32 patients. We collected these, like the Kanya classification, the feeders, and the approach, and also the embolization material used in the operation, and also the operation time, and also important, the most important is the immediate result from the operation. So as you can see here, we did it SOV approach in all of the 32 patients. As I remember, 5 were STV approach, and the 27 were FV facial vein approach. And nearly all of the patients acquired complete immediate embolization. and all of the symptoms are recovered. 3 of the patients had complications. These are temporary oculomotor nerve palsy, which were all recovered within 3 months. So we submitted our results to the Journal of Neurointervention Surgery, and it was accepted earlier this year. And in this research, we found a very interesting result that 76% of the patients, the drainage pattern of the facial vein is obviously different from the classic anatomy the knowledge in the textbook we know that the facial vein usually drained into the ICV, but on the contrary, in this case series, the facial vein, most of the facial vein drained into the ECV, and here is a video of our to illustrate this technique. It should be around 5 minutes. So as we all know that the chance SOV approach are usually difficult because the junction of the SOV to the FV or STV is usually with a very sharp and angled structure. So here's this video is to show how do we conquer this difficulty. We usually did it by technique, what do we call the microwire looping technique. Here we can see the microcatheter is advanced into the STV, and now we can see. So here, yes, when we enlarge the part of the junction, so we can see there is the huge angled and narrowed the junction. This is a schematic how we did categorize the microcatheter into the SOV. It's very easy to go the facial vein or to the nasal root veins, which we didn't want to go. And so we use a finger to press the angle to block the, and we also use the microwire looping technique to conquer the angled veins and to the narrowed the junction. And actually, it's very easy. It's very tricky technique. Now, once you advance the micro catheter into the fistula point, it's very easy to embolize the fistula. Now, this is another the way to enhance the supporting system, also by finger press. We press the supporting catheter to enhance the supporting force. So usually we use 1 coil or 2, most of the case 1 coil to form the concrete structure to prevent the reflux of the onyx. And this is another case to show how we categorize the SOV by FV approach. It's bilateral blood supply. Both branches from the bilateral ICAs and ECAs, and this is the video showing the microwire looping technique. So we navigate the microcatheter into the facial vein using this technique, and also to categorize the angular veins. And by using this technique, we can prevent the vein rupture during surgery, and it's very important. So once you canalize the fistula, and you can easily coil this fistula. So in this case, we didn't play any coil. We just inject the onyx slowly. Yeah, so just within the fistular point, and we'll acquire total occlusion. This is a post-operative contralateral CC angiogram. Okay, so I'm gonna illustrate this technique in a very difficult case. In this case, this patient was priorly embolized using chance artery and other IPS recanalization approach, but unfortunately, this patient experienced ectopic embolization during surgery, and the fistula was not totally embolized. And we can see the onyx cast in the artery side, in the cavernous sinus, and bandages in the MCA branches. This patient experienced a minor stroke after surgery, so she was very afraid of the second surgery. So we tried to do it safely, and we can see from here, this is a 3D reconstruction of the veins. We can see here there's several when you zoom out, yeah, there was a very angered and the stenosis of the junction of the SOV and the facial veins. So it is very interesting that in this case the facial vein drained not into the ICV or ECV. Actually, it drained into the anterior jugular vein. This is the only case that with this anatomy. So anyway, we succeeded to advance the microcatheter into the fistula, and we inject just a little amount of onyx, and this patient acquired total embolization after surgery. So when during the review process, there are several comments from the reviewers, and one of the reviewers said, "This is strong worded that SOV approach should be the first line strategy in management of cavernous sinus dural arteriovenous fistula with occluded IPS." And also recently we got a letter from the reader. There are some appreciations and also some inquiries and some recommendations from the reader. We try to tackle his inquiries. As the drafting of this report, the transfemoral venous SOV route was selected as the initial approach for endovascular treatment in 47 patients at our center. The immediate complete embolization rate was 97.87%. A total of 25 patients underwent post-operative DSA follow-up, and 15 patients were monitored by MRI imaging. All patients were regularly followed up by telephone calls. In terms of post-operative complications, we observed only 3 transient cranial nerve palsy in 3 cases, and all of which resolved within 3 months. So we continued our study in a multi-center the pattern. So we enrolled eight centers in our next study. So this is the schematic of our ongoing study. We enrolled, as I remember, 178 patients in our the ongoing study. We compared the invisible approach with the visible approach. That means the IPS recanalization approach with the SOV approach. So this is a study design. In 8 patients, we acquired all the data of the patients with the occluded IPS, and this is the primary results from our ongoing study. There are no significant difference in the baseline of the two groups. The 78 patients in the SOV group and 108 patients in the IPS recanalization group. The baseline data were not with significant difference. However, when you compare with the initial treatment success rate, it seems like it is a little bit higher in the SOV approach, and the complications were significantly lower in the SOV approach. So, and also we compared the embolization material used in the two groups. The onyx were without any difference, but when we compare with the coils, seems like in the SOV approach, the coils was less than the IPS group. So we further categorized the SOV approach into different subtypes by different criteria. So the SOV approach was divided by 2 subtypes, which are simple type and also the complex type. So in the subtype comparison, so the time of the operation is significantly less in the simple type SOV approach. But even with the complex type of SOV, the surgery time was not significantly increased. And also we compared the material use in different subgroups with the same idea that in ISOV approach, in this group, the embolization material was less used compared to the IPS approach. So this is all the results from my speech tonight. And welcome to join our multi-center study, and thank you for your attention.
Thank you,
Okay,
Professor Xu. Thank you, Professor Xu, for your wonderful lectures, and you showed a large experience of transfemoral to SOV approach to treat the cavernous sinus dural AVF. And I have several comments. First, as you already showed us, trans-arterial embolization to the cavernous sinus dural AVF is not the first choice of treatment because of the risk of cranial nerve palsy and onyx migration to other arterial territory. So I agree to the first choice of the treatment is the transvenous approach. And my second comment is in the case with IPS occluded, but we tend to try first to reach the cavernous sinus through the occluded IPS. In most cases, we can access the cavernous sinus. Of course, there are some cases in which we cannot navigate through the IPS. Then we chose as another route to SOV. And you showed a very beautiful techniques in the video, and I'm very impressed, and I really enjoyed your video. But one concerns about this transfemoral to SOV approach is the length. Oh,
Yeah.
If very tall patients,
Mhm.
we cannot reach the
Yeah.
region with the ordinary microcatheter or so. I have a question to Professor Shu. Do you use any distal access catheter or longer microcatheter in the case to treat via this SOV approach? Distal access catheter or what kind of microcatheter did you use? Did you select?
Okay. Thank you, Professor Takahiro. This is a very good question. You remind us to, collect the data of the length of the patients. But actually, in the East Asian population, the height of the patients are less. I think less. The average might be around 170, or maybe it should definitely less than 180. So in all of our cases, the idea of using SOV approach is, yes, I agree with you that most of cases when you recanalize the IPS, you may success, but sometimes you might need some, luck, to recanalize the IPS, right? So the idea of SOV is because we can see the approach, we can see actually on the roadmap. So we started to try this, approach, and fortunately, we succeeded most all of the cases. So so the supporting system we use is basically the Envoy guiding catheter. It's 90 centimeters in length, and the microcatheter is 150 centimeters. So most of the cases we use the Anchilon microcatheter from the EV3 corporation, and some of the cases we use the Headway 17 microcatheter, which is from Microvention, Terumo from Japan, right? So the most of the cases the length is enough. Just in one case, as I showed in my PowerPoint, the most challenging case is when the FV drained into the anterior jugular vein. It's almost I use it's almost I can show you in this slide. Can you see my slide?
Please share your slide.
So you have to share it again, please.
Please
Okay,
share.
I can share this. Okay, let me share. Here. In this case, yeah, in this case, the microcatheter can be guide into the just this point. It's very close to the fistula point, but the length is not enough. But only in this case. So most of the case, the length of the microcatheters are enough. Yeah, I don't know if that can my answer will be satisfied with your question.
Yeah, thank you for your question answers. And my recommendation is direct jugular vein puncture. It's solve the
Okay.
problem of the length to
Yeah,
direct.
yeah. Okay.
Yeah. So did you any experience with direct jugular vein puncture? No.
Actually, I tried it just in one case earlier before 2016, but I failed in that case. I'm actually we were not familiar with the anatomy of the SOV, the segment, and in the in the puncture, direct puncture process. So we try to avoid this. And also, I heard a severe complication during direct puncture. So we tried another. Yeah. So we tried another way. We use this femoral vein approach. So yeah, that's the main idea. But actually,
Okay.
I think direct puncture may be much easier for experienced surgeons, even with especially with ultrasound guiding.
Mhm.
Yeah.
There are raised hands from the panelists. Dr. Afzal, yes.
It was really great presentation. Your result is astonishing, and I'm interested in micro catheters to use. You said you use echelon and headway. As we know, it's not tip is not detachable. So how you avoid the stacking of these catheters inside the distal veins near the fistula? And the second question, you said that you use pressure cooker technique with coils, 1 or 2 coils. And do you use 2 microcatheters to reach the place? For example, you place one near the fistula and the second one, or you just place the coils and go through the coils to the fistula side. And if the microcatheter gets stuck with the onyx, how do you deal with it?
Okay. So is that all?
Yeah.
Okay.
It's all.
Okay. Thank you for your question. It's very insightful. I'll start with your second question. We initially we start with the idea of using 2 microcasters. That's so-called the pressure cook technique. But in our case, it's not much a different technique. We use we name it as a solid concrete technique rather than pressure cook techniques, because we don't use the coils as a emboli, behind the onyx. We just use the coils to prevent the reflux of the onyx. So we don't use 2 microcaster. We just use 1 microcaster. We place just 1 coil just to catch the coil, to catch the liquid engines, to prevent the reflux. So actually, you don't use too much coils. Just use 1 coil is enough, and no matter how much the length of the coil is. So that's my understanding of this technique. And I'm sorry, I kind of forgot your first question. Can you repeat again? The first question?
The question was about these catheters tips are not detachable. So if it gets stuck, how do you deal with it? Yeah.
Okay. Yeah. These microcasters are not detachable. Yeah. So the idea is to withdraw the microcaster without any problem. So we use this coil mixed with onyx technique to prevent the over embolization of the microcatheter. So if you the reflex within 3 centimeters, it's okay, because this microcatheter is much bigger in diameter than Malason microcatheter. It can be easily withdrawn without any question. Yeah. But if you use this microcatheter in the veins under subarachnoid veins, you have to be really careful, because the SOV is much safer. It's not in the subarachnoid space.
Thank you very much, Professor.
Yes, Ben, quick question.
Yes, and just a quick question. So I would like to ask about I saw that you use the finger techniques. So in your reality, do you use the less shelled gloves to protect your hands from the radiation? And also, I would like to ask about. I can see that you use the finger technique for the suborbital to the SOV, but have you tried to use a direct cannulation of the SOV? So in our center, we use it with the cannulation of the SOV with our ophthalmologist. So it is also a quite good technique to use.
Yeah. Okay, thank you for your comments. Yeah, I think the second question is kind of same of the question from Professor Takahiro. We didn't try to use the direction punction because we in our center, we are not kind of really tight connection with eye doctors, so we kind of not very familiar with the direction punction approach. But I agree with you that this approach is much you can be considered in several cases. The first question is the protection of our hands, right? Yeah, yeah. We try to use the gloves to protect the hands of the assistant doctor. But actually, the X-ray exposure time is very short. It's kind of okay. Yeah.
Right. Thank you very much. So I think there are no further questions. We can move back. I think there is a raised hand from Biswas. Yes, Biswas. I'll send you to the panelist list. Yes, Biswas, you can ask a question.
Hello, Raja Sensei. Thank you for the opportunity.
Okay, please ask your question, Biswas.
Yeah, sir, I would like to just ask one question based on my a case we have dealt just 1 week back. It was a type D CCF. We have exhausted transarterial and transvenous route, but there was remnant. So we have to go through the supraophthalmic vein route. We exposed under microscope the supraophthalmic vein, then we got the excess. I just need to ask, is there any special tips to localize the supraophthalmic vein for the transvenous route?
Yeah, did you try ultrasound as a guidance? For starters, I think we might be not familiar with anatomy during surgical exposure. I personally didn't do surgical exposure of the SLV. All of the cases are managed by direct, in those vascular technique. So based on the information from literature, I think the direct exposure of SOV it should be without any problem if we did by the experienced ophthalmic doctors, but we don't have this experience. And very sorry, I cannot answer your questions. But if you can show me your angiograms, I think it might be some way to conquer the SOV approach we're using just vascular means.
So we'll move on to Prof. Takahiro Ota to hear his concluding remarks.
Yeah, today's second lecture was very impressive, and transfemoral trans-SOV approach is very useful in the patient with Cavernous AVF. Of course, we performed several cases as the Professor Shu showed us, but in the endovascular treatment, for the patients with the dural AVF, we need to have several techniques. Transfemoral, trans-SOV, everything. So today's lecture is very educational to young surgeon, but not only young neurosurgeon, but veterans. So Thank you for your lecture, Professor Shu. And today is a very nice webinar, I think. Thank you for Professor Raja.
Well, thank you very much, Sensei. I think it's time we can wind up today's event. So I'll close this officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to thank both the speakers of today, Dr. Shunsuke Shibao and Dr. Liang Su, as well as the chairs, Professor Roy Thomas Daniel and Dr. Kahiro Ota, for the time and support for the ACNS webinars. A very special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel. And as I want to mention to all of viewers that this was being broadcasted on YouTube, WeChat and Zoom, and as of now we have around 800 people who are logged in through different channels. So thank you very much. So thank you, my dear co-host Liu Bun Sen, for joining me today, and all the other esteemed delegates of the ACNS. Until we all meet again online, it is bye bye from all of us. Thank you very much for joining.